Good morning. I'm Peter Moskovitz. I'm the chair of the Board of Directors of RSDSA, and I'd like to acknowledge my fellow board members who are present. If you would just stand for a second and wave. Thank you very much for your service. I'd especially, a little lower, that's good, thank you. I'd especially like to thank our communications director, Alexis Johnson, and our executive director, Sharon Wiener, for organizing and putting on this conference. They have done a wonderful job. Sharon and Alexis, would you stand wherever you are and wave to us? Well, they're working. They're hard at work. But they did this all, and we're very grateful. I have a few housekeeping announcements. RSDSA respects your privacy, everyone's privacy, and therefore we ask you please do not record or live stream anything in this conference. It is being recorded, and it will be edited to protect everyone's privacy and published on YouTube, so it will be available to you after. Please remember that while all of the information that you receive here is, we hope, for your benefit, it is not individualized to your specific needs, and we ask you please to consult with your personal physician for those personalized needs. We have a quiet room that is available if you so need, and we have blankets and pillows if that is required, and just ask one of the volunteers if you would like to take a break during the course of this conference. So we welcome you all, and it is my pleasure to introduce Mr. Bryan Pope, Esquire, who will introduce our first speaker.
Good morning. So, when we knew that the RSDSA was going to have its first in-person conference for the first time in 6 years since the onset of COVID, we knew there would be no other person that we could get to come give our keynote address than Dr. Pradeep Chopra. He is the only one who would be appropriate for this kickoff, and the reason is because he is a superstar. He's got the street credibility and chops to educate us on CRPS like no one else. If you've been to any past conferences or seen any of the virtual conferences that we put on in the last 5 years, then you probably have seen him, and maybe you've seen a video of his on the RSDSA YouTube. Dr. Chopra agreed to accept our invitation, and we are so honored to have him here today. He's double board certified in pain management and anesthesiology, and he got his medical training at Harvard, doing his residency, fellowship, and master's. Over 25 years of experience treating complex chronic pain, multi-system disorders. He's the assistant clinical professor at Brown University Medical School, and the director of Interventional Pain Management Center of Rhode Island. His private practice, the Center for Complex Conditions, where he sees patients, he takes a root cause multi-system approach rather than just suppressing symptoms. His treatment plans integrate neurology, immunology, and autonomic function to provide comprehensive, personalized care. And recently, Dr. Chopra testified as an expert witness on behalf of the Kowalski family in the Maya Kowalski trial against Johns Hopkins All Children's Hospital. Basis of that lawsuit, of course, was the Take Care of Maya Netflix documentary, which so many of us have seen, and which did such a great job of educating the world and our country on CRPS and its horrific, painfully disabling condition. Court watchers agreed that Dr. Chopra was indeed the key star witness, in the trial, which resulted in over a $250 million verdict on behalf of the Kowalski family. So let's get this conference started with our own true superstar, Dr. Pradeep Chopra.
Thank you. Thank you so much for that introduction, Brian. I'll send you the check. This presentation took me weeks and weeks and weeks to write up. I went and I dug through the literature. Who's timing me? Alexis? You? Okay. Can we just coordinate our times?
I have a 15-minute warning at 10:45.
No, I just need to sort of get an idea. So it's 1.5 hours, right? Oh, all right. So we start now? Okay. So this presentation is not for something or not against anything, it's just facts. At times, I do have my own personal opinion, and I'll give that to you. I'll tell you it's my personal opinion. But we need to understand. Now, a lot has changed in the world of CRPS. We've come to understand that it's not a one disease. The cause of CRPS is multiple causes, and I'll show you. So anyway, this is a disclaimer. I just want to make sure that I have no conflict of interest. Now, what I did was, in the past I've done this, is I labeled them over here. Green is effective, yellow is worth trying, use caution, and blue is just nerdy stuff. Okay, and apparently past audiences have loved that, so I started using it again. So the diagnosis of CRPS is very clear cut. There's no ifs and buts. This is one of the few pain conditions which have a checklist. 1, 2, 3, 4, you have to meet that criteria, and that's it. So there's no confusion. It's not like saying, I have a headache, and then there's all kinds of reasons for having a headache. But this is pretty clear cut. And this was put down it's known as the Budapest criteria. And the Budapest criteria over the years has been proven again and again to be correct. They just tweaked it a little bit, called the Valencia consensus. But the main thing over here is the patient must have continuous pain disproportionate to the inciting event. So if you have a foot sprain and the pain just continues for years, then that's the main criteria, nothing else. I mean, there are other things, but that's one of the main criteria. No other condition better explains it. These are the signs and symptoms of CRPS. The pain starts in one limb. It can start in the spine, abdomen, and pelvis, but it's usually, for our purposes here today, it starts in one limb. It's a constant pain, never goes down, and there's intermittent flare-ups. So I always ask my patient, does this pain ever go down to zero? And of course, it doesn't ever go down to zero. But then do you have spontaneous intermittent flare-ups, like you're watching TV and suddenly it shoots up? There's a temperature difference. Sorry, I'm still getting used to this. There's a temperature difference between the two sides, color difference, and I'll show you all this. The swelling is kind of iffy. It's usually in the initial stages, and then in the later stages, you don't see as much swelling. Some days you see more swelling, sometimes no swelling. And the area of pain is much larger than the primary injury. So if it started in your left ankle, pain eventually spreads to your entire leg and elsewhere. You may have an uncomfortable sensation to soft touch, bed sheets, light breeze, everything, anything, Even bringing your hand close to it is painful. Nail changes, they grow either faster or they're distorted. Hair growth changes, there's either dark hair or lighter hair or hair falls off. Not the hair on the head, hair on the legs or the arm. Skin changes, thin and shiny, is usually in the initial stages. In the later stages, you don't see it as much. Now, the reason why I'm teaching you all this is because there's a lot of misdiagnosis in CRPS. So oftentimes there are doctors who don't really understand it and they're like, all right, I did your surgery and I don't know why you still have pain. It's probably CRPS. But you've got to know whether it's a CRPS or not. Skin lesions, I don't see them often. Very rarely you'll see pinpoint lesions, and they're pretty painful. And increased sweating. There are no tests. There are no objective tests. And like most medical conditions, there's no objective testing. I have migraines, or I have schizophrenia, or manic depressive. There's no test. You can take MRIs of my head, nothing will show up. Literally, nothing will show up. So the diagnosis of CRPS is based on a clinical exam. You talk to the patient, you examine the patient, and I showed you what to see on an exam. These tests, a lot of times we've had other doctors argue, and I've had people say all sorts of things, medical professionals, oh, the bone scan was not positive or whatever. None of these are indicative of CRPS, diagnostic. But your doctor may get these tests done if he wants to rule out something else. That's fine. But of all these tests, I would not recommend getting a skin biopsy or an EMG easily, because obviously you don't want somebody sticking a needle in that painful limb. So why is it so difficult to treat CRPS? And that's the problem. So what I did was I looked at this. So think of the nervous system as in two parts. The first part is the brain and the spinal cord. Okay, that's called the central nervous system. That's the central control system. And then you look at the nerves that come out. Okay, these are the nerves that go to different parts of the body. That's called the peripheral nervous system. And the entire story starts in the peripheral nervous system, but then it moves to the central nervous system. I'll show you soon. So let's start with the day I have an injury, okay? Right after the injury, the body raises an alarm, okay? And these are called alarm chemicals. And that's normal response. So if I break a leg, there's an alarm response. But that alarm does not switch off in CRPS. That's the problem. It does not switch off. And the chemicals that cause this alarm are these pro-inflammatory cytokines. You know what cytokines are? Cytokines are text messages. Each cell in your blood sends a text message to the next cell. Hey, make this person's life miserable. Cause some pain. And that's what cytokines are. Neuropeptides, these are little proteins called CGRP, substance P, and we'll talk about CGRP a little bit more, and mast cell activation. So mast cells are cells that live in our blood and they cause inflammation. So this is a normal response, but the problem is once the fracture heals, the alarm should switch off, but in CRPS it does not switch off. So what happens is the body gets alarmed and it sets off the fight or flight nerves. So we have two kinds of nervous system. There's a nervous system that is automatic. It's called the autonomic nervous system that controls fight or flight. And those nerves get activated. Now here's the thing. The autonomic nervous system does not carry pain. In normal circumstances, it does not. So when you're in fight or flight, you're not in pain. But in CRPS, it does cause pain. So pain nerves so the chemical that these fight or flight nerves release is called adrenaline, and everyone knows adrenaline. So these nerves release adrenaline, and the pain nerves should not care about that because that's how they are designed. But in CRPS, it does. These pain nerves are triggered. So adrenaline triggers your pain nerves. And hence, for the longest time, and still now, we consider CRPS to be a sympathetically mediated pain, which means it's mediated by the autonomic nervous system. The autonomic nervous system becomes painful. So this triggers stress, cold, startle reflex, and it flips your pain from hot to cold. And then what happens, so we've got the initial injury, the alarm won't shut off. The smallest blood vessels, the little capillaries, the small blood vessels in my hand, they do not open and close properly. And now there's poor oxygen being sent to my fingers. And that causes cramps, fatigue. Whenever you use the limb, it turns blue and cold. By now, so it's, up till now, it's in the periphery. Now it goes into the central nervous system, which is called central sensitization. Central sensitization explains a lot of chronic pain conditions. Why do people they had back pain years ago, and now they still have back pain? Lots of conditions, but it applies specifically to CRPS. And I really need you to understand this, what central sensitization is. So now my hand is sensitized, the alarm won't shut off, and there's a barrage of pain signals going up into my spinal cord, into my brain, and the brain is trying to send signals down to my arm to suppress these pain signals. So there are signals going up and down. A simple touch becomes painful when it is perceived by the brain. By now, there's so much signals going up and down that my hand becomes sensitized, and a simple touch is painful. All right, here's my, this is in the Smithsonian, by the way. So you're honored to see this. That's the brain, and that's the spinal cord, okay? Looks pretty naked. Now I've added the nerves to it. These are the nerves that go to different parts of your body, your arms, your legs, okay? And then one of them starts to misbehave. This is the one nerve that, remember it got injured because you had a fracture or a sprain or surgery, or somebody stuck a needle in you, and that nerve gets painful. So it's releasing all those chemical inflammatory, remember the cytokines and the neuropeptides, and the alarm won't shut off. So now it's getting all alarmed, there's alarm signals going up. And eventually what happens is these signals go up, and then the brain is sending down signals to like, okay, stop guys, stop. And so there's a barrage of pain signals going up and down. And that makes the entire central nervous system, the brain and the spinal cord, sensitized. And that, in brief, is called central sensitization. So in CRPS, the root cause of your pain is central sensitization. That's the problem. And so somebody may have pain, CRPS in their left hand, but loud sounds become painful, bright lights become painful, because these are signals that the brain is getting, and it's getting really annoyed because the brain and the spinal cord are already sensitized. So the problem lies in the brain and the spinal cord, not in these nerves. So this pain that was in my hand, my arm, has now gone into my brain and spinal cord. It's a little different concept, but I'm trying to explain it as best as I can. So what really does happen in CRPS? What happens in the brain and the spinal cord? Like, if you take a microscope and you look inside, okay, what's going on? So the brain and the spinal cord is made up of something called glial cells. Glial cells. For the longest time, we didn't know what they did. So that's why they're called glial cells, like glue. Their purpose was to hold the nerves in our brain, the packing material. But now we know that no, these glial cells do a lot. Not just CRPS, but otherwise also. They're part of the immune system of the brain and the nervous system. They're like scavengers, they're like janitors. They take care of the nerves in the brain. They clean up, they remove any debris, they remove any stuff, they take care of that. I'll switch to that side later because I don't want people getting a crick in their neck on that side. But this is what it looks like in the brain. So this is a nerve. This is my one brain nerve that I have. Okay, it's called a neuron, and right next to it, these creepy-looking creatures, they are all glial cells, and they have different types. There are different types here, but they are really like next to the nerve cell. They're packed tightly, and so these guys get activated. They get upset because of the central sensitization. So this is my other simplistic way of looking at it is, all right, so this is the nerve in the brain or the neuron, and then you have the glial cells next to it, and they take care of this nerve. But then when there's a barrage of pain signals coming up from that arm, remember, there's all these signals. So these glial cells, that's their job, is to protect this neuron. So they get activated. They're up in arms all about it. They get activated. And when they get activated, they release chemicals that cause inflammation. Inflammation, believe it or not, is protective for us. But when it goes out of control, then it's not protective anymore. So with these chemicals being released, what happens is these chemicals cause inflammation of the neurons in the brain and the spinal cord. That's what happens in central sensitization. If you look deep inside, the neurons are all inflamed, the glial cells are all activated. So the problem lies in these cells. It's not the neurons, they are not at fault. It's these glial cells that are all upset about it, releasing neuroinflammatory chemicals. So in long-standing cases, so it's spreading. This is always a worry with both doctors and patients, that you don't want this CRPS to spread. It's bad enough to have it in one limb, but you don't want it to spread. It happens in long-standing cases. It happens with additional trauma. So if I have CRPS in my left hand and I have a trauma in my right hand, let's say some phlebotomist is sticking needles on my arm 20 times, yes, it may spread there. So as the central nervous system becomes more sensitized, normal sensations become painful. There are three types of CRPS, but we'll just stick to the two types. The third one is not that. CRPS1 and CRPS2. In CRPS1, we don't know which nerve is damaged. My whole arm hurts. But in CRPS2, I know the exact nerve that is damaged. So there's a nerve that goes down my arm called the brachial plexus. There's a nerve that goes down my leg that's affected. In fact, CRPS2 was the first CRPS to be discovered. So when back in the First World War, when Dr. Mitchell discovered all these bullet injuries in the arm where the nerve was affected, it was CRPS type 2. The reason why I'm saying this is there are several reasons. One, CRPS type 2, which is a nerve damage, does not usually spread. That's the good news. The other good news is that it may be fixable. What if there's a nerve damage? What if there's a nerve compression or something? And if we go in there and fix it, we might be able to fix it. The problem is that most physicians do not differentiate between CRPS1 and CRPS2. Unless they're experts at CRPS, they don't differentiate. And it's really important to differentiate because the treatment can be very, very different. So the symptoms are similar in CRPS2 as CRPS1. There's a major nerve damage. So here are some examples of CRPS type 2. I see this a lot, thoracic outlet syndrome, which means that the nerve that goes down your arm gets pinched over here. And then when it gets pinched, they have CRPS in their arm. And usually you'll see that in car accidents or fall on their arm, you'll see that. In the leg, the common peroneal nerve, so the nerve that lives on the side of my knee, oftentimes a fracture of their leg in fact, last night at dinner, we were discussing this exact same thing, fracture of the leg, and the nerve that goes down the leg gets affected. And so they have CRPS or tarsal tunnel syndrome. So like I said, it doesn't spread. Are there people here who have children with CRPS? Okay. All right, so joint hypermobility, and this is not children, this is adults also. When you have loose joints, the loose joint can stretch the nerve and they can develop CRPS type 2. This really bothers me, is a blood draw. Oftentimes you go for a blood draw. Remember, in CRPS, the veins are very friable. They break easily. And oftentimes you go for a blood draw and the junior-most phlebotomist is right there who graduated yesterday and is in there fishing up and down, up and down. And the patient's screaming in pain, "Oh, don't worry, it's okay." No, it's not okay. That's what happens. Fracture, if they put a cast, if somebody has a fracture and they put a cast, the pain should get better within hours. Within hours. That's the whole idea of putting a cast. As long as the bones are not moving, the pain will start to get better, or maybe just a little bit, some soreness, but not increase. If it continues to increase, take that cast off. Take that cast off. You're developing CRPS. You don't want it to get to that point. You're still at the peripheral sensitization stage. You're still, the pain is still in your limb. So get that cast off. The pain should not increase if the fracture, it's common misconception. Oftentimes doctors will just say, "Oh, you had a fracture. Yeah, you're going to have pain." No, you're not going to have pain if they put a cast on. That's the whole idea of putting a cast on. Sports injuries, ankle sprain after playing a sport, spine surgery, oftentimes during spine surgery, it's very delicate surgery and a nerve gets nicked. So almost any trauma can trigger CRPS, but these are the ones that I see commonly. So here are some things to protect yourself and protect others. Is if the person cannot get a blood sample on the first 2 tries, then say stop. Go get someone else, and that more experienced person, and try a different limb. Okay, so if you feel a shooting pain while your blood is being drawn, you need to stop right away. Now the problem is for patients who receive IV ketamine, they have to get stuck every time they get a ketamine infusion, however, when they get it. And like I said, the veins are very friable. So these are some of the things to watch out for. That getting stuck with an IV again and again is a risk for spreading CRPS. So consider getting a chest port or a PICC line or something. Now, this is an example. This is a young lady. She actually came to an RSDSA conference we had in Lafayette. And she was just like, "There's nothing for me, I need to go home." And so I said, let's have a look. She came in, we did ketamine infusions. She had this pain. This is from a cast. So we did ketamine infusions on her, got her pain under a little control, and then I examined her elbow, and sure enough, her elbow was dislocated. She had fallen, she was labeled as CRPS 1, and then when the pain was a little better composed, we found out that the ulnar nerve, that's the nerve that travels down your arm, was compressed by a dislocated elbow joint. Talked to the surgeon, he went in there, fixed it. She's fully functional now, fully. Completely recovered. So that's why I'm trying to say it's important to find out whether it's CRPS type 2 or is it CRPS type 1. Now, this is just to show you, this is either CRPS. There's swelling. You can see the socks, line on the lining of the socks, and then you can see the color difference between the 2 sides. The reason I'm saying all this is you should be able to self-diagnose CRPS. And you should meet the criteria, the Budapest criteria. It's there all over the internet. So there we have swelling, and then we have, you can see the nails, they're all crumbling. Again, you can see a big difference in the color in the 2 sides, and you can see swelling here. See, you can see some of the bony, you can see some of the bones in the ligaments. Here you see nothing. This is another one. lots of hair growing on the knee. This is a CRPS limb. Lots of hair growing on the limb. This is another example. Always, whenever you take a picture, because not oftentimes you'll have a color change when you're in the doctor's office. That's what usually happens. Take a picture of both limbs together so they can compare it. And so that's, again, take both pictures. This is a thermal scan that I do. It's a kind of a special camera that looks at the heat map of the body. So instead of doing a single temperature point reading, what it does is it looks at the entire temperature, the heat distribution in the entire limb, and then you can measure temperature at specific spots. And so you can see the temperature over here is 69.3. The temperature on the right leg is 76.3. Any difference more than 1 degree is considered significant. And most times, the difference is a big difference. We see a lot of difference. So this is this is called a thermal scan. I mean, if your doctor wants to do it with a laser thing, that's fine, but they should measure the temperature, or you should do your own temperature measurement. So management of CRPS. So a lot of our understanding on CRPS has changed over the years. I'm going to switch to that side. I'm getting dirty looks from the left side. So our understanding of CRPS has changed over the years. At first we thought there's one cause and that's the cause, and we just treat it. But now we're starting to understand, as we start to understand other diseases, that different people with CRPS can have different reasons for having CRPS. And one of them is over here. There's a receptor, we'll talk about this a little later, called the NMDA receptor. And this is responsible for causing central sensitization. So that's one reason. There's also glial cell activation. So how do we stop that glial cell? You remember those glial cells, those creepy-looking creatures in the brain? Those get activated. So how do we decrease that? Low-dose naltrexone is one of the drugs that can be used. We do know that there's an immune modulation. So the immune system gets affected. Other theory is that the receptors remember the flight and fight nerves we talked about? The chemical that's released in a flight and fight nerve is adrenaline. And adrenaline normally does not affect pain fibers, but in CRPS it does. And so are these receptors where adrenaline works, are they causing hyperstimulation of the pain fibers? So when you're in flight or fight, you're not in pain. But in this case, it can cause pain. So using drugs that can block adrenaline, like prazosin or clonidine or some of these antagonists, would that help CRPS? Now, these are just thoughts. These are theories. These are thoughts. It's impossible for a physician to figure out what your cause of CRPS is. It's very, very difficult. So the other one was, is there an immune component to it? So you can IV immunoglobulins. So you have, the immune system is there to protect us. And sometimes this immune system goes haywire and it's not able to detect enemy agents versus your own body. So it attacks your own body. It affects your own nerves. So these antibodies that attack your own nervous system, do you have those? Is that the reason why you have CRPS? So immunoglobulin is, it's called IVIG. They get these healthy antibodies and they give you these healthy antibodies. These are the good antibodies. And so that you overwhelm the rogue antibodies. And then you can do what is called a plasma exchange therapy, where they wash out your plasma for bad antibodies, and then they give you some healthy antibodies to see if that helps. Now, we'll talk about neuromodulation, spinal cord stimulators, also root ganglions are some options. And then you have, this is a little more in the research stage, biomarker identification. So the identification of biomarkers such as the microRNA might help in early detection and treatment of CRPS. So a lot of this is under research, a lot of this is under there are theories, but it's different. When I gave this similar talk in the last 6 years, 10 years, I've been giving this talk where we said, oh, there's only one reason for having CRPS. Now we think, no, there may be multiple reasons why a person could have CRPS. So I just want to point out, by the way, see that blue mark? Blue dot means this is just theory stuff, okay? The yellow mark means no harm in trying it. It won't do any harm. And so everybody here has already tried half of these drugs, gabapentin, pregabalin, milnacipran. This is a good drug to try. Amitriptyline, nortriptyline, this is a good drug to try. Duloxetine, nah, not so much. Opioids have very little role in CRPS. I would not recommend opioids, not because of the addiction stuff, not because of that. Do you know what the incidence of addiction in pain patients is with opioids? 0.3%. There are more people addicted to coffee in this room than to opioids. Okay, that's from the CDC, by the way, not from my brain. So opioids, the problem with opioids is they increase glial cell activation. So those creepy characters get all worked up, and that increases central sensitization. But you can try low-dose opioids. There's no harm. If your joint hurts, you have knee pain, because you have CRPS in your foot, but your hip hurts, your lower back hurts, that's not CRPS pain. And if a low dose of opioid helps, great. It's nothing wrong with that. So try it out, yellow. Topical creams are useless and expensive. Why are they useless? Because we know that this is in the brain and the spinal cord. This is no more in the hand. It's gone. The pain is coming downwards. It's downside to your limbs, not starting from here. And these creams are extremely expensive, except for one. We'll get to that. Low-dose naltrexone, this just completely baffled us when it came out. It increases endorphin production. The strongest painkiller in this world is endorphins that you are producing in your own brain. So it stimulates your body to produce endorphins. It increases this called opioid growth factor. Which helps with tissue repair and healing. And we do need that in CRPS. Most importantly, it works on this receptor called TLR4. They're toll-like receptors, which decrease glial cell activation. And that's the best part about LDN. It is a disease-modifying agent. It's not a disease-masking agent. We don't want masking. We want cure. We want disease-modifying agents. So this helps with pain, fatigue, and inflammation. Now, remember, when I talk about drugs or any treatments, it doesn't apply to everyone. If it was 100%, then it's probably not true. So yeah, I can take a Tylenol for my headache and it won't work. But somebody else takes a Tylenol, it works beautifully well. So there's always a difference. So when taken in small doses, it's disease modifying, decreases glial cell activation, stabilizes the immune system. Because remember I told you, there is a theory that the immune system could be responsible for causing CRPS. So in 2021, there was a company that got an orphan drug designation. Not approval, but designation. So this company went to the FDA and said, look, we want to try out LDN for patients with CRPS, which means that the company gets certain privileges. If they do the research and if the research is successful, the FDA then approves it. And then it approves it, then the company gets certain privileges, which means they get boatloads of money. But unfortunately, they haven't done anything about it. They're just sitting on it since 2021. And believe it or not, 2021 was in the middle of the pandemic. So I was like, whoa, the FDA has time to look at all this? And so the dose can be anywhere from 1.75 to 4.5 milligrams. And it's fine. You can always start at a lower dose and climb up. It's okay. Getting used to the drug is always helpful. It may cause some insomnia. You can take it in the morning. It causes mild headaches. Then they're gone after some time. But what patients may report is increased physical activity. I still remember this lady. She came in and she said, I don't think it's helping me. I said, okay, well, then we should stop it. And then she said, and then while talking, she said, I can now stay on the treadmill for half an hour. I said, so how much were you before that? And she said, oh, barely 5 minutes. So kind of things that you figure out, patients do not realize that it's helping them. The flare-ups, it doesn't stop flare-ups. So the flare-ups are not as acute, and there's better tolerance to pain. And don't give up. If you don't have any side effects, stay on it for at least 6 months. We've had long discussions at LDN conferences about this, and the general consensus was 6 months. And it's not expensive, and it's worth the try. It has to be made by a compounding pharmacy. This was a paper that we published back in 2010. No one would believe us. No one would believe me that I was using LDN to treat CRPS. And so finally, Mark Cooper was a brilliant scientist, and the two of us, we published this paper back in 2010. Didn't take off for a while, and then finally it did. Now it's like they're teaching it in pharmacy schools. But the one thing I want to tell you about LDN, take it once a day. That's the key. I can get into the details, it'll take a lot of our time, but I just want you to know, there are people who are prescribing it 3 times a day, 4 times a day. More is not always better. So once a day, whether you take it in the morning or at night, doesn't matter, but once a day. Topical magnesium is great. We are all short of magnesium. We're all deprived of magnesium. So topical magnesium, you can buy magnesium cream online. Not the oil, not the spray, but the cream. And you have to apply it yourself. So one of the things about CRPS is you can touch your limb yourself. It won't hurt as much as somebody else does it. It's the same principle that you can't tickle yourself. So apply topical magnesium. Don't do the spray, don't do the oil. IV magnesium, even if you just gave IV magnesium, let's say your doctor says, oh, no ketamine for you. So even if he gave you IV magnesium as an IV, it'll help somewhat. Oral magnesium does not work as well, but it does work if you have constipation. Ketamine, let's talk about the magical drug everyone's talking about. So you remember we talked about in central sensitization, how the glial cells get all upset and activated. Let's forget that. What else happens is that these receptors are key, lock and key mechanisms. So this is a keyhole. These receptors get activated, and they're called NMDA. They get activated. So NMDA receptors, normally, we all have them in our body. But during central sensitization, they get activated. Not only do they get activated, they get sensitized. And they also proliferate. It's so creepy. All of a sudden you have CRPS and these NMDA receptors start proliferating all over. And they also become very sensitive, which we can use. So when these NMDA receptors are activated, they increase pain. And they also decrease sensitivity to opioids, which is why opioids don't work. One of the reasons why opioids don't work so well in CRPS. So ketamine is the best NMDA receptor blocker. There are others, but they're all very mild, not very effective. But this is a strong NMDA receptor blocker. It's a very safe drug to use. It doesn't cause depression of your respiration and breathing or your blood pressure. It's very strong analgesic, even when given at low doses. But taken orally, it's not reliable. That's the problem. So you have to take a lot more orally, and it may work, may not work, and you tend to have more side effects. But when you take it, when you take it as an IV or under your tongue or as a nasal spray, it does work well because it's bypassing the GI system. So in 2021 and in 2022, I don't know what happened at the FDA with CRPS. in the middle of the pandemic. They must have like, we don't have anything to do. Let's just give us an approval. Really? Anyway, they did. So 2 companies were, FDA granted an orphan drug designation. I want to stress on that part, designation. That doesn't mean approval, it means designation. They said, all right, you guys, you 2 companies can do all the research you want. You're allowed to do that for CRPS, and if the research is successful, then you're allowed, then we will give you permission to market it or approval, and then you can make boatloads of money. And these 2 companies have done nothing about it. So how do you take a ketamine infusion? How do you start taking a ketamine infusion? And this is my protocol, okay? Different people respond to drugs differently. So I don't know if I'm going to do well with ketamine or not, IV ketamine. So what I do is, the first thing to do is try ketamine nasal or under the tongue first. It's pretty benign. You can spray it under your nose. And then if it works, if the ketamine nasal or sublingual helps a little even a tiny bit, then the patient is likely to respond to IV ketamine. If the patient has no response, but has no side effects, even then it's worth trying it. Because remember, the nasal ketamine and the sublingual ketamine is a very tiny dose. So if there's no side effect, it's worth trying it. But if the patient has severe side effects, they start throwing up or they start having all sorts of reactions, then it's not worth trying an IV ketamine. So this is kind of a test that I like to do. It's administered in low doses, not in high doses. In low doses, it works very well. It decreases central sensitization. And this is results that came out back in 2004. And it showed that about 85% of people respond to ketamine. Now, like I said, not all drugs work 100%. So this is one of the drugs. This 85% does make somewhat sense. Unfortunately, the FDA approved the ketamine nasal, but they approved the wrong form. And that's a different set of politics. But they approved the wrong form, the S form, for treatment of depression. So what happened is everybody said, oh, you can use it for, so technically FDA has approved ketamine. Why not? And people with CRPS have depression. People with chronic pain have depression. So all right, let's just give these people ketamine. But now they start giving them IV ketamine. But unfortunately, they're not giving it in the correct protocols. They're giving them really low doses. They're not monitoring these patients carefully. Lots of stuff that I get to hear. So now ketamine clinics have popped up everywhere doing it incorrectly. Usually, anesthesiologists are trained in this. Especially if they are pain trained, then that's fine. But anesthesiologists are very well trained. But there are other physicians who are trained in giving ketamine, understand the nuances of ketamine. They're well experienced. They don't have a, be careful. If it's like a mill, they're just giving ketamine, left and right, then it's different. I wouldn't go there. But they understand CRPS and ketamine. And it's not as simple as sticking a needle and then just giving the ketamine. There's a lot more that goes behind it. And what goes behind it is, one, remember the room has to be very quiet, no bright lights, because those lights and sounds trigger hallucinations. This avoids the side effects. Qualified people must always be present, and it should be fully monitored. So there are 2 parts to the ketamine IV. There's the loading dose, and then there's the booster dose. The loading dose is, just start on a Monday. You start at a really tiny dose, infuse it over 4 hours. Then Tuesday, you go up a little bit. Wednesday, you go up a little more. And Thursday, you keep going up until you find that sweet spot. You start at a very low dose, increase slowly, done over 4 hours. Add magnesium to the infusion, and that helps boost the effect of ketamine. There are some centers that add propofol. There's no value to it. There's no harm to it, but there's no value to it. It doesn't affect CRPS. but it does help you sleep. I don't recommend doing it, but still, no harm. Boosters are really important. So oftentimes, it's not a one-time do and go. So after you've had the first loading dose, so you've had it for 7 to 10 days, the booster is done about every 4 to 8 weeks, depending on how the pain is, how the response is. So as the initial effect of ketamine wears off, the glial cells get back to their action. They start getting activated again. And at this time, you slam them with another dose of ketamine, and that brings down the glial cells. Now, of course, the protocol has to be customized to each patient. The dose, and even the booster dose, it's not a fixed amount. Depending on the season, let's say there's a hurricane coming through, the pain is really bad, winter months are bad, summer months are not that bad, so the dose has to be varied. Most of the side effects of ketamine are temporary and short-lived and reversible. If you stop the ketamine, those are all gone. Like hallucinations or colorful dreams, these are all gone. There are no long-term side effects that we know of. It's been approved for over 30 years. It's been used a lot. We haven't seen any side effects. Temporary side effects are nausea and vomiting. Nasal spray or under the tongue, sublingual, also known as troche, you can use that for flare-ups. So if somebody's getting ketamine infusions, they can get these nasal spray or troches for breakthrough pain. So there's a flare-up. Do not try oral ketamine. It's useless, unpredictable side effects. People were telling me about how much they were being charged. And I was kind of shocked because the drug is not expensive. Other drugs that are used with it are also not expensive. The main expense is in the staffing and the monitoring and all that, but it should be crazy expensive. And I was listening to all these numbers people were throwing out, they have thrown out at me, and like thousands and thousands and thousands of dollars. It does not make sense. Yes, it is expensive to have staff and monitoring and all that, but it shouldn't be crazy expensive. Thermal scans. So you remember I showed you that picture, scary picture? Here's it is again. So what I did was, before the ketamine, I took this picture, a thermal scan, and you can see, wherever it is dark, the temperature is lower. The lower the temperature, the darker the color is. Okay. Lighter the color, the warmer it is. So you can see this is super dark, 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 dark. And over here is partially dark, and then it becomes really warm here. Okay, so the temperature was 69.3. And then after ketamine, look how warm the limb looks. In fact, both limbs, even though the CRPS was on this side, even the other limb looks great. And the temperature went up to 91 degrees. Huge jump in the temperature difference between the two sides. So if someone says ketamine is not right or something, this is clear proof it does help. But unfortunately, it's not forever. So you have to keep hitting it again and again, and eventually it'll start to stay down. This is another example, and you can see the color difference. This is before the ketamine was 71, after ketamine 92. This is another one, pre-ketamine 74, and then 92. And you can see how the limb looks so bright and beautiful. Same thing here. I just threw in some pictures here. And then I went in even a little higher. Even though there's no CRPS here, I looked up there also, there's a temperature difference. Ketamine does not increase body temperature. It does not do that. If anything, it'll drop the temperature. This is a lady who has it in her hands, and you can see it's in the right hand, and it extends to mid-forearm, and you can see the exact line. And there's no CRPS up here, and then you have CRPS down here, and it's awful CRPS here. And then she has some on the left. That was a spreading she had. And then after the ketamine, you can see it over here. Same thing here, the difference between the two sides. This was before the ketamine. She couldn't even hold up her hands. We had to use a cushion to rest her hands. And look at there's literally no blood flow in the fingers, even both sides. And then after the ketamine, she didn't even need a cushion. She was just sitting there, and you could see the color, the temperature difference. Same thing here. This is somebody else with a left-hand CRPS, and look how it's warmed up. So this is me, not just my experience. So over the last 25 years of using all of these modalities, nerve blocks, spinal cord stimulators, spinal pumps, IV ketamine, the best results I've found is from IV ketamine. One, because it's reversible. If something happens, you can always stop it or slow down and then change the dose. You can alter it. Over the years, patients have, so, like I said, you give the loading dose and then you give a booster dose every 4 to 8 weeks. And over time, we see those 4 to 8 weeks become longer. It becomes 3 months, becomes 4 months, 6 months, and then it becomes once a year, and then they're done. So like all treatments, not everyone responds to ketamine. It's not easy for both the doctors and the patients to go through an infusion. Ketamine is not fun to get. Okay, it's pretty disturbing, but patients do it because they have this horrible, terrible pain. They do it. And the doctors have to carefully monitor them and make sure they're okay and have to keep adjusting the dose and all of that stuff. But it's all worthwhile to achieve function. Autoimmunity, so autoimmune dysfunction means that you have antibodies in your body that they don't recognize enemy agents versus your own tissue, and they start acting against your own nerves. And so you have bad antibodies. And some patients with CRPS have been shown to have IgG antibodies against autonomic nerves. Autonomic nerves are remember the flight or fight nerves? Those are the autonomic nerves, which then triggers CRPS. And I said IVIG is is an infusion of good, healthy antibodies. So they get they get a bunch of people who donate their plasma, they get these antibodies and they infuse it. It is expensive, but it's worth a try. Antioxidants, so what happens is, these are called free radical scavengers. What happens is, because of all the processes that are going on, there's a lot of stuff going on in patients with CRPS, and they produce what are called free radical scavengers. These are unstable molecules in our blood. And these unstable molecules are harmful for our tissue. They destroy our own tissue. Now, so the literature, there has been literature. In fact, there was a literature that came out from Netherlands on guidelines for CRPS. It's worth a read. They have 2 sections, one for physicians, one for patients. It's worth reading them. They're a little old, but they're worth looking at. So these are some of the antioxidants you can try: alpha lipoic acid, vitamin C, DMSO. This is not something that you eat. It's a cream or a lotion. N-acetylcysteine, all available over the counter. Alpha lipoic acid, and actually in Germany, it has been approved for nerve pain. In Germany, they have a lot of drugs their FDA approves a lot of these over-the-counter type of drugs for treatment of different conditions. And so there are no trials in CRPS, but it has been shown to help in neuropathy, which is nerve pain. So worth a try. It's best given IV. And I think there are a few centers in the United States that do it IV. I don't know who they are and where they are, but I've heard of that. But if not, you can try it as a pill. The dose is anywhere from 600 to 1,200 milligrams per day. Start low and then increase slowly. Vitamin C, this is an incredible drug. There have been 2 really good papers that came out, and they looked at, can we prevent CRPS? And they did, and it was successful. So the 2 papers, I've mentioned the 2 papers here. They gave 500 milligrams to these patients and before the surgery, and they found that those who didn't get vitamin C had CRPS, and those who got it didn't have CRPS. It's not as straightforward, but that's what it meant. So my question is there any value to someone already who has CRPS? No harm in trying. It's vitamin C, it's lemonade. Try it. Okay, but don't go crazy on it. I've had patients who take 2,000 milligrams of vitamin C a day. It's not. That's just expensive pee. So 500 milligrams per day is good enough because it may at some point, if it prevents it, it's probably helping it. It's an antioxidant, we know that. Acetylcysteine, you know how people have that cold allodynia, the cold hand, the cold feet? It helps with that, actually. 600 milligrams 3 times a day for 3 months. Try it for at least 3 months, and then you can stay on it if you want. It's actually it's a pretty good antioxidant. It's also good for the liver, but that's besides the point. The NC10 rule. So I have this, what I call as an NC10 rule. So let's say you have different, so we talked about different treatments over here, right? We talked about antioxidants, ketamine, LD, and blah, blah, blah. So the principle is that if you can get 10% from one, 10 from another, 10 from another, 10 from another, if you have 5 10s, you've got 50%. Don't expect 100% from one. So it's 10, even 10%, and 10% is not a lot. So if you can get 5 10%, then that's good enough for me. So that's the NC10 rule. Neridronate, I'm going to talk to you about this because this is as scams go. So in 2012, there was a study in Italy, okay? It was done by a physician by the name of Adami. Anyway, they took 41 patients that had allodynia and all that stuff, and by day 1, no one had allodynia. They infused this drug, and by day 1, everybody was better. And after a year, no one had CRPS. And so obviously it was like, oh my God, this is exciting stuff. I have 6 patients from that study that they said it didn't work. Anyway, so they said, okay, let's duplicate this study in the United Kingdom and the United States. And in both cases, the study was stopped early because of an independent group that was monitoring the study said did not find any improvement in pain. Forget the day 1. Found no improvement in pain. They said, stop this study, this is not right. And this is an independent group. The figures from UK, I was able to find them. From the US, they've been hiding the figures. I've called them and they won't give me the figures, but all we know is that they did give a statement that the study was stopped because of futility of something end results. Anyway, it was stopped after 3 months because the lack of improvement was shocking to the investigators and patients. Listen, if something works 100%, it smells, right? This is the company that did this study in the US, I think, and I think also in UK. It's called Grunenthal. They did the study. This is their statement. This is their actual statement from their website. And this is these 2 yellow highlighted stuff. Grunenthal decided to discontinue its 2 ongoing phase 3 clinical trials of neridronate. The outcome of the interim analysis for our neridronate phase 3 trials is not what we had hoped. Now, that drug got sold to a new company. I forget the name of the company. They contacted me to do the study, and I said, well, first give me the data from your previous studies, and they won't. They said, we won't give it to you in writing, but we'll tell you on the phone. I said, no. So they won't. So they're starting new trials in the United States. The requirement to participate in the study is that you should have CRPS for no more than 6 months. And you should have warm CRPS. You should have bone changes. Now, bone changes is not part of the diagnostic criteria of CRPS. It's not in the Budapest criteria. And it should be only CRPS 1, not CRPS 2. But they're very strict about who they want. Here's the problem with this. It is extremely difficult to diagnose, impossible to diagnose in 6 months, because let's say I have a fracture, and I get a fracture, and they do a surgery, they put me in a cast or whatever. You're going to give it 6 months of time to see whether it's the original injury or whether it's CRPS. By that time, 6 months are over. The second is bone loss does not develop. If it develops, does not develop for 6 months after the CRPS develops. But they want all their patients to be having bone loss. But the bone loss gets better as the disease progresses. And then most of the patients, like I pointed to you out, is CRPS type 2, not CRPS type 1, and they're not going to take CRPS type 2. The good news is you can get it for free, of course, because it's part of the trial. It does have its own side effects, but they're not bad. But there were people who took a second mortgage, spent a ton of money, were bankrupt going on this medical tourism thing to Italy, and they had this whole scam of hotels and everything. But it was unfortunately sad. Spinal cord stimulators. So this one I was very torn about, okay, because I wanted to give you the right answer, and I must have read like 100 papers on this just for this presentation to find the real answers. And eventually I said, all right, I'm just going to give them the facts. Okay, so the spinal cord stimulator is a device that's implanted under your skin. It's a generator, and there's a wire that goes into the spine, and that generator you can control with a remote, and it'll help with pain, with CRPS pain and other pain conditions. There's another one called the DRG stimulator, dorsal root ganglion stimulator. This is more specific. It goes to the exact nerve root that's causing this pain, and it stimulates that nerve there. So I looked at the studies, and I've tried to summarize them, but I can't give you an opinion on this, okay? So the initial benefit, and what I found was that after 3 to 5 years, it's not anymore effective. It's not because the device fails, but I think it's because the spine, the nervous system, adjusts itself. So they did a Korean study. So they took this data, the Korean government took this data from 373 patients, and they said, how many of them had it for how long? And it was found that most of them had pulled their spinal cord stimulator out after 4 years. So between 4 and 5 years, they had pulled it out. They didn't give us the reason why it was pulled out, but they said it was pulled out. That's all they knew. The theories were that, why would you pull it out if it's working? So it's probably because it didn't work or they had some complications. We don't know. This was a study done in 2006 and 2008. It did help. The spinal cord stimulator helped initially, but the benefit lasted only 3 years, which matches up with the other studies. There was a Dutch study, and they followed these patients for 12 years. It helped 41% of the patients, which is not a bad number. 41% is about half, I would say. But the maximum pain reduction they found was 30%. So I looked at the studies that were like the big studies that the FDA looked at. So this was a study they compared the spinal cord stimulator with the dorsal root ganglion stimulator study. And this study, here's a study that was published in 2017. Now, the dorsal root ganglion is specifically for the legs. It's not for the arms. So they put the DRG stimulator in the spines of 73 patients. And in another 73 patients, they put spinal cord stimulators. So they put half the patients had spinal cord stimulators, half the patients had DRG stimulators. And the success in the DRG group was fantastic. It was 61 out of 73. But in the spinal cord stimulator group, it was 54 out of 73, which is still not bad. But here's the problem. There were 28 authors in that study. All 28 authors were paid by the company that manufactures these stimulators. That got me going. Now, I understand that the companies do, if they want to test it out, they can, donate these stimulators and say like, yeah, hey, I want you guys to try it and see. But these authors were paid by the company into their bank accounts. Half of these authors were paid by multiple companies who make this device or owned stock in the companies. So not just the company that was paying these 28 authors, but there were other companies who make spinal cord stimulators were paying half of these people, or they own stock in the companies. It has to be disclosed. When you publish a paper, you have to disclose conflict of interest. To me, this muddies the water a lot. The numbers look fantastic, obviously, but again, I don't know what's the truth. So I looked at another paper. 1 year, so this was another one, 1 year outcomes. They did this. This is a device that they use which does both spinal cord stimulator and DRG ganglion stimulator. They looked at them at 1 year in the treatment of chronic neuropathic pain, which is not CRPS, but it is in the family of CRPS. So they put this DRG spinal cord stimulator device in the spine of 51 patients. 19 of them failed the trial. So they do a trial before they implant the stimulator. And it is standard that there will be some people who will fail the trial. So they eventually implanted it in 32 patients. So that's 51 minus 19. Of these 32 patients, 7 of them said, remove it, we don't want it. So only half of the 25 of the original 51 patients had the device for a year. Overall, the pain improvement was 56%, which kind of matches our previous figures. 51% to 41% patients improve. There were 12 authors. One of them was an employee of the company that makes the device. 9 of the authors were paid by the company as consultants. So this smells. It smells a lot. Now, I don't know if I'm mistaken, if there is something that I'm missing here, and I did very deep research into this, like, is this allowed, is this not allowed, and it isn't allowed. You know, I'm an evil guy. I'm like, they paid all these people, how come they didn't pay that one guy? He died. No, he died of old age, don't worry. He died. And he was one of the giants in the pain industry, actually. It was amazing, but he passed away. Anyway, so this is what I want you to understand. Okay, I'm not against spinal cord stimulators. I'm not for spinal cord stimulators, but you have the facts. Consider the risk of implantation. It's not a ketamine, like, okay, you're having side effects, let's stop it, and you go home and you're fine. It's not that. It's something that's going to be implanted in your spine. But also remember that you'll get a benefit for 3 to 4 years. After that, you may see no benefit. Now, if I have CRPS, I'll take the 4 years if it is easy. But if it's in the spine, I would be a little more hesitant. But even if it works, and even if you like it, the benefit is about 30 to 40%. That's the benefit. But what I would advise is that the physician who's placing the stimulator is well experienced. There are a lot of mom and pop shops out there putting spinal cord stimulators left and right, and they put it in, they never see the patient again. It's awful. So they go on a weekend, trip to Orlando, get a training in a hotel, and then they come back and then they start putting it in. Be very, very careful. So the physician must be well, and this should not be the first option to try. They should try other things. You fail other things, then try this. The only advantage one of the advantages of the spinal cord stimulator is it is FDA approved, and insurance companies will approve it. So it's a fight, but they will approve it. But now Medicare, which does not require prior authorization, Medicare is starting to look at it, they're looking at it cockeyed. And so there are 5 states in the United States that Medicare now wants prior authorization on spinal cord stimulators. So anyway, Frozen joints, be careful. So somebody has CRPS of their wrist and hand. The tendency is not to move it. And what happens is the shoulder joint freezes up. So if the CRPS does even get better, the shoulder is now frozen. And we see this in feet also. The ankle gets frozen, and even if the CRPS gets better, they still can't walk because their ankle joint is frozen. So the best thing is, even if if the CRPS is in your hand, keep moving it. Keep moving the fingers, keep moving the elbow. Even if you have to use the other hand to move it, but move it. As long as you're moving it, it's getting greased, and it's getting greased, it won't stiffen up. And one day, when CRPS does go away, you at least have your movements there. That's the one thing to be careful about. Same thing with the legs. Keep moving them. This is a patient who actually I suspected, this is from the internet actually, but I think she has CRPS type 2. The nerve on the side of the leg is gone, and now this patient, probably she has a frozen ankle. Now, even if the CRPS goes away, that frozen ankle is not going to work. So this is what I just explained. Surgery in complex CRPS. So you have CRPS and now you need a surgery, okay? Let's say you need a gallbladder surgery or your appendix or something like that. What do you do? What precautions do we take? Start gabapentin or pregabalin 2 weeks before the surgery. Start on vitamin C before the surgery and continue it after the surgery. These are precautions to take. I think this is on the RSDSA website. Ask the anesthesiologist over there to use ketamine as part of their anesthetic. Tell them, like, listen, you can use whatever you want for anesthesia. Can you just add a touch of ketamine in it during the surgery and after the surgery? Apply numbing medicine to the IV site, and the IV must be put in at one shot. To get the most experienced person to put it. Okay, the other thing is, if it's a lower body surgery, then an epidural or a spinal anesthesia is perfectly fine to get. But request that the chart or your whatever records be marked. Do not touch left hand. Do not touch left arm. Get a big old sign in neon lights flashing, do not touch left arm. I can guarantee you, the way the medical system is right now, people are going to forget. They're short-staffed, they're in a rush, they're in a hurry, people are going to forget. Always take somebody with you. Put a sign over the bed. Of course, avoid loud sounds. Put a cage over the affected limb. And have a friend or family member who is going to watch that arm or your leg like a hawk. Do not touch it. Because oftentimes when they move the patient from the table, they inevitably move that arm or grab that arm. And so just be very careful of this. Conditions associated with CRPS, POTS. We see this quite a lot actually. This is a condition where people get lightheaded or fainting, especially when they move from lying to standing. They have heart racing, they have fatigue, brain fog. They can have headaches, cold hands and feet, and brain fog. I can't go into the details of the treatment, but it's pretty standard. You'll find it on the internet. Mast cell activation syndrome, this is a nasty condition that we see associated with CRPS, not the cause of CRPS. And if you recall in one of my first slides, I said when your pain starts, mast cells get activated, and this is called mast cell activation syndrome. It's a relatively new condition. Patients feel like they're having a flu-like symptoms. Everything hurts, they feel sick, they feel tired, they're cold, they're hot, they want to just stay curled up in bed. Lots of fatigue, and they have diffuse body-wide pain. It's not just that limp. But it comes and goes. They may have skin flushing and itching. They're sensitive to a lot of drugs and chemicals, headaches, sweating, especially at night, skin flushing after a shower, and belly pain. Desensitization, that's the red mark there. I would put 5 reds over there. Do not do that. That is an extremely bad idea. And here's the problem. I have not been able to convince physical therapists not to do it. And the first thing they do is they put your foot in a bucket of sand or rice or something like that. The idea of desensitization was, what they do is they'll take a towel and they rub it over the painful limb. Or they'll put it in a bucket of rice and have you move your foot in it. And the theory is that they're trying to retrain the brain. There's nothing to retrain. Your glial cells are activated. There's no retraining here. There's also another theory is kinesiophobia. Like, okay, because you've got pain in your foot, you're not moving it because you're afraid to move it. Yes, I am afraid to move it because it hurts. But rubbing a piece of rough towel over it is not going to make it any better. So this constant barrage of pain now makes your central sensitization worse. So in my 25 years, I've never seen anyone say, oh my God, the desensitization was fantastic. I love rubbing my foot with sandpaper. No, it doesn't work. Sorry, don't do it. Physical movement, yes, move your limbs. Like I said, don't hold them still. Even if it hurts, gently move it. If you can't move it yourself, move it with your other hand or move it somehow, gently move them. Keep the joints, lubricated. Physiotherapy does not have to be hard and difficult. It's not like, okay, get on the treadmill and start running even if you have CRPS on the left leg. No, it doesn't work like that. You've got to control the pain first before you can do any of this exercising. Muscle pain and dystonia. So people have lots of muscle spasms and dystonias. This is the old drug, Cinemet. It was approved for treatment of Parkinson's. It increases the dopamine levels in the central nervous system, helps with muscle spasms and dystonias. And you can try 1 to 2 tablets a day. You can go up to as much as 4. It comes in a strength of 25/100. CRPS in children. So we don't have any children here. But children do actually well with CRPS. That's the amazing thing. But they get treated very poorly. So once they go to the hospital, they are said, get into this boot camp physical therapy. We don't care whether you have CRPS or not. We don't care. And so it creates a lot of psychological problems in these children. It's often, if you don't follow their physical therapy regimen, then it's called behavioral disorder or conversion disorder. And then the parents are blamed for it. They are doctor-seeking or Munchausen's. Generally associated with connective tissue disorders like Ehlers-Danlos syndrome. I'm going to kind of skip over this because of time. I know. Did you say 15?
Yeah, that's
Oh.
you got more time from me. Watch me.
The check worked. Look at that. All right. If they might call it amplified pain syndrome, that means be careful. They don't believe you. They're like, it's in your head. So walk out. If someone says amplified pain syndrome, walk out. There's no such term as amplified pain syndrome. It's CRPS and it's CRPS. That's it. There's no two ways about it. This is skin lesions in CRPS, okay? So you get these little painful blisters. And you know what works for it? Ketamine cream. I was so shocked by it. Ketamine cream works for blisters. Well, I guess I was wrong. Not all creams and lotions. This is one of them where it does work. You don't see this often, but these are very painful blisters. Service dogs, we have one here. I think his name is Gunnar. Love it. I love having a service dog. These are amazing. They're a little expensive. They're a little bit of hard work, but they can make a big difference to your life. Trust me. I have seen them save lives. Service dogs are not seeing eye dogs. They are dogs that know exactly when you're in pain. They comfort you when you're in pain. They're your constant companion. They sense your distress. They can call for help. These are incredible dogs. This one is red. Nerve blocks, not helpful in most cases. Steroid ganglion blocks for arms, lumbar sympathetic blocks are not for legs. The reason, so my theory on treatments is, look, if it's not going to do any harm, try it. Okay, there are lots of remedies out there that we don't know about. Some things work, some things don't work. But if it can kill you or paralyze you, do not try it. And these can kill you or paralyze you. I have seen cases that come across my desk where a person had a stellate ganglion block and is now paralyzed. So do not try these. And even if you get some help, it's only for a short time. It's not worth it. If they say that this is because of diagnosis of CRPS, it is not. The Budapest criteria is very clear about it. We actually have Dr. Norman Hardin here. He's one of the key authors for the Budapest criteria. And these nerve blocks are not helpful. They're dangerous. I used to do them when I graduated, and then I realized, like, okay, these don't work. Therapies that are not useful CRPS. You can try them, but they're not useful. The only thing that they'll do is make your bank a lot lighter. Mirror box, transcranial magnetic stimulation, vagus nerve stimulation. We can read them all. Hyperbaric oxygen, lymphatic drainage, scar tissue, sound wave therapy. I don't even know what that is. But none of these work. There are no diets that make a difference. This is what it is. But will they do you any harm? Probably not. They will harm your bank balance, but other than that, they won't kill you. Upcoming therapies that we're hoping will work out is the microRNA. And it seems to be a promising biomarker for CRPS, both for diagnosis and treatment. So we're hoping for this. IBD blast and tadalafil or Cialis. These have a mechanism of action. It works on an enzyme called phosphodiesterase. And it can have a potential to help people. IBD blast is not available in the US. Cialis is available. They're especially good for cold CRPS. The new weight loss medicines, the GLP-1, there's a group called GLP-1 and GIP agonist, Zepbound and Mounjaro. There's no good studies on it, but there's a lot of anecdotal literature on that they do help with nerve pain. Nerve pain, CRPS, that's how I look at it. Maybe there's a future, but yes, something to look forward to. It can help. And if you have the chance to try it, worth a try. IBD blast, you can actually buy it from this link. And it's sold under the name of Kitas. But there's also a drug called pentoxifylline that's available in the US also. It's a prescription drug. So you have IBD blast, Cialis, stay away from the guys, okay? GLP-1, GIP agonists, IBD blast, pentoxifylline, worth a try, no harm. Scrambler therapy, I don't know. The FDA approved it as a TENS unit. But when I talk to the Scrambler people, they insist that this is not TENS unit. But in any case, the FDA said, okay, whatever you say it is, it's a TENS unit. You can buy a TENS unit for $10 on Amazon. No harm in trying it, except in children. I've seen some really bad side effects in children. But there's no harm in trying it. It should be done by an experienced doctor. Right now, there are all kinds of snake skin salespeople around. Like, oh yeah, I know how to use a scrambler therapy. But go to an experienced doctor, try it, it can help. But remember, give it 3 or 4 tries. And if in 3 or 4 tries you don't see any benefit, walk away. I think it is expensive. But it's not a treatment by itself. It should be in addition to others, like the NC10 rule. It should be one of those 10 things to try. But again, it can't do any harm trying it. But it's worth, if it does help, great. If it doesn't help, it's okay, you tried it. This is CGRP. I mentioned this earlier on. CGRP is a small protein that's released when a nerve gets inflamed. So when a nerve is angry, it releases a small protein called CGRP, calcitonin gene-related gene peptide. It's currently approved for treatment of migraines. And there is a lot of similarity between migraines and CRPS. Migraines, light bothers you, sound bothers you, your scalp gets allodynia sensitivity. There's a lot of similarity between the two. And again, it's a nerve, CGRP is released by inflamed nerves. So I'm hoping that someday we'll have done enough research on CGRP antagonists for treatment of CRPS. It's funny, I was looking at my old slides. I talked about CGRP back in 2012 being the future, and it's come out now. It's available easily, but not for CRPS. They may have a different dose for CRPS. I have to acknowledge the RSDSA. I've been working with the RSDSA for a good 25 years. I've attended a lot of their meetings. This is the only organization that does anything for CRPS patients. They are so dedicated. The board is so dedicated. They work so hard, and they really do their best to get as much support as they can. But they can't work by themselves. They need you guys to support them. There is no other organization. I mean, there are a little bit here and there, but this is the one organization that has stood out and that has championed the cause of CRPS. They do fund research. They do fund people who need help. They do all sorts of good things for patients with CRPS. And so I would definitely support them in any way I can. Thank you. I know.
7 minutes.
This is the first time in my life I finished early. Uh-oh, here comes Dr. Moskovitz. Uh-oh. Shh, everyone, quiet.
Thank you.
Hi again. I do want to repeat that the opinions expressed in these presentations are not direct medical advice for everyone. They are information generally, and we advise you to do your own research, of course, and speak to your personal physician to address your personal needs in your CRPS care. We have a break for about 15 minutes, and then we'll reconvene with the next speech. Thank you.